Perfect. So hi, everyone. My name is Nina Reciprocal. I'm a physician at Boston IVF. Thought I'd start just by giving everybody a little bit of an overview, just into some background about our clinic, about the treatment options that we offer. So a little bit about what you all should be looking for when you're looking for a fertility specialist. There's a lot of things actually, for everybody has slightly different priorities. I mean, obviously you want to think about who you might want to work with, the team. And you also want a center that's going to treat you with respect, recognize your relationship, and of course, a center that has a lot of availability of various treatment options and a lot of experience. A little background about Boston IVF. We've been treating a diverse array of patients, including LGBTQ patients, since our inception. So we have a lot of experience with working with couples and individual or single patients who are navigating this journey. And ultimately, we hope to be your partner in the process of family building. A couple of other softer criteria, also very, very important, is you want a center that accepts your insurance plan. And we are proud to partner with a lot of insurance plans, including some of the more progressive plans that are very comprehensive in coverage, and you want a center that has good proximity. We are very happy that we can offer care across New England, also in New York State and lots of other states as well. So proximity is very important when you're looking for a center. So check out our website, and hopefully we are able to service a location close to you. People often ask, what is a reproductive health checkup? What am I signing up for if I'm registering as a new patient? So first and foremost, it's going to be an appointment with a reproductive health specialist. That could be, if you're looking for something expedited, potentially one of our nurse practitioners or PAs who are specialty trained. Or it could be one of our reproductive endocrinology and infertility physicians. Typically about an hour, and that's because it takes a lot of time to assess your reproductive health, and particularly if you're presenting with a partner. It is kind of an in-depth interview about both of your histories. We'll review plans for fertility testing, so what kind of fertility testing is indicated for your specific case, and then we'll also review some potential treatment options. So what kind of considerations might we have? What could the pathway and what could the timeline look like? And then you can also set up a time to speak with our financial coordinators who can review your health insurance if you have coverage for treatment, or review costs for treatment. And then we have each of our providers, each of our physicians works with a dedicated nursing team. So after consultation, you'll have an opportunity to touch base with the nursing team, ask any questions about the testing, and actually schedule the testing and get started with your reproductive health evaluation. So if you are somebody who's assigned female at birth, has a uterus and ovaries, and we're going to be ordering a pelvic ultrasound. Conventionally, these are done transvaginally if you're comfortable with that, because the anatomy is quite small. In many cases, the uterus is fairly small if you've never been pregnant before. And then the ovaries can be as small as 2 centimeters. So we're talking tiny, maybe the size of a quarter or a little bit larger. And so in some cases, they're quite a bit larger and they can be seen transabdominally, but for many patients are small and are difficult to see that way. So we recommend a transvaginal scan. At that time, we're going to be counting the number of potential eggs developing on the ovary. That's called an antral follicle count. And we'll also be evaluating the uterus for any fibroids or any anatomic abnormalities, and looking at the ovaries, seeing if there's any cysts on the ovaries or any abnormalities. So that is the purpose of the ultrasound. If you're not comfortable with the transvaginal ultrasound, just tell your provider. We can do it transabdominally. You just need to have a full bladder, and we can do our best to evaluate the anatomy that way. There's some blood work as well. Some of the key elements of blood work that you have probably read a little bit about is the ovarian assessment. And for that, we use a couple of tests. We use the day 3 testing that's done timed to your reproductive cycle if you do get regular cycles, or we can do it at random if you don't get regular cycles. And don't worry about that if that's an issue that you're concerned about. The testing consists of a test called the FSH, follicle stimulating hormone. We check that against the estrogen level as well. And then primarily the main hormone of interest for us is the anti-Müllerian hormone, the AMH. And that's a really important assessment of your ovarian activity and how it relates to other people in your age group. So really critical test, and something that we like to have assessed or rechecked every year in order to see if there's any interval change. Some prenatal labs, if you're intending to become pregnant, very important to make sure that your blood count is good, that you don't have any antibodies in your bloodstream, that you're immune to childhood vaccinations, and that we also require STD testing for all of our patients doing treatment. Your doctor will probably also talk with you about genetic testing. Genetic testing is indicated for most patients pursuing fertility treatment, and it's important to have a genetic panel done to understand which donor you may want to work with, or which donor may be a candidate, maybe a choice, because donors are screened with large genetic panels, actually. In most cases, donors are screened with genetic panels that range in 200, maybe 300 genetic conditions. And if they come back as a carrier for a condition, you want to know if you're a carrier for that condition, if your child could be at risk of developing that condition. So genetic testing is important, and according to what your goals are, you may be offered sort of different panels of genetic testing, but it's important to have some insight into whether you're a carrier for cystic fibrosis, spinal muscular atrophy, and then other hosts of genetic disorders that are more common in certain populations, such as the Ashkenazi Jewish population, or potentially the Mediterranean population or the Asian population, where certain conditions are a little bit more common. If you're electing to proceed with donor sperm, you'll probably be tested for CMV as well. CMV stands for cytomegalovirus, and it's a virus that a lot of us have had exposure to. It can be transmitted through many different mechanisms. It can be sexually transmitted, but usually, but not the majority of the time. And those of us who work in healthcare and childcare are typically more likely to be positive or have exposure to this or have antibodies against it. And if you're negative for it, your provider may recommend that you choose a CMV negative donor who's never been exposed to this virus as well. So that's kind of gives you the background of some of the blood work that would be recommended. And there's also another evaluation that would likely be recommended before considering moving forward with donor sperm, particularly insemination with donor sperm. And that's a test called the HSG, or hysterosalpingogram. That's a study where dye is passed into the uterus by passing a little catheter. So that's what you're seeing. You're seeing that straight line at the bottom. That straight line is the catheter that's passing through the cervix and instilling dye into the uterus. And you can see the uterus is labeled. It's roughly an upside down triangular shape. That's a normal appearing uterus. And then you can see that dye in a sort of a curlicue fashion passing through the right and left fallopian tube. So those are normal patent fallopian tubes that are allowing the dye to pass through. And the dye is radiosensitive, and we take pictures of the dye passing through the anatomy with X-ray. So we're able to have a really good understanding of the inside contour of the uterine anatomy, as well as the patency of the fallopian tubes. A really good study, and I would strongly recommend that you have this done prior to pursuing donor sperm insemination. Very, very helpful information, and essentially gives you a safety check to understand that you are not wasting your time, in the setting of tubal blockage. It's really a shame if tubal blockage is diagnosed after many treatment cycles have been completed, because sperm at the end of the day is pretty costly. There is a lot of benefit to doing a fertility checkup prior to starting treatment, including home insemination. So you can learn a little bit more about the pros and cons of both approaches, but also to review your medications to make sure that your medications are pregnancy safe, to manage any underlying health conditions, to optimize your health before becoming pregnant, and ultimately preconception counseling, making sure you're taking a prenatal vitamin, making sure that your lifestyle habits are appropriate for becoming pregnant. And then there's a lot of people who have gynecologic conditions, which they may not understand the full impact of on their fertility. So assessing for uterine fibroids, ovulatory problems such as PCOS or polycystic ovarian syndrome, which is actually the most common cause of ovulatory dysfunction, and also endometriosis, which is an inflammatory condition that affects the success of fertility treatment and may impact the fallopian tubes as well. So for all these reasons, very important to get a fertility checkup, even if you just find out that everything is kind of optimal and you can go ahead and get started. These are very helpful things. And the other piece, of course, is to understand a little bit more about your family history, whether there's any risks to you or potentially your child based on your family history. There's a couple things that your doctor may talk with you about optimizing prior to proceeding with fertility treatment. So healthy habits, avoiding habits that are hazardous to your health, such as smoking or other use of drugs and things like that. Really working towards a healthy weight. We can't all get to a perfect or ideal body weight before starting treatment, but at least heading in that direction and starting those healthy habits that can stick with you in pregnancy to optimize your chance of having a healthy pregnancy and a healthy baby. And that includes regular exercise, making sure you're getting about 150 minutes of exercise per week. You can break that up as you wish, 30-minute segments, 50-minute segments, but consistent, regular exercise such that you are working towards reducing insulin resistance and optimizing your health, and also optimizing your mood, getting some endorphins. Very, very important part of getting healthy for pregnancy. We talked a little bit about this, but you want to, if you're a smoker, you want to stop vaping or smoking, starting a prenatal vitamin, no drugs, including marijuana when you're on your pregnancy journey, and minimizing alcohol. For most of us, that means 1 drink or less per day on average, because heavier alcohol use, about 2 drinks per day or higher, is associated with decreased or impaired fertility outcomes. And of course, no drinking when you're pregnant, because that can impose a risk of fetal alcohol syndrome. So we at Boston IVF have been around since the 1980s, and we are a full spectrum fertility care center. That means we can obviously do your fertility evaluation, do your testing, and we do offer a broad range of treatment options from not aggressive at all the way to very aggressive, including IVF treatment, egg donation, and surrogacy. So we do offer all of those testing options. So if you are interested in treatment, definitely chat with us about what's available. I think you'll be pleasantly surprised about our range of treatment offerings. So I'll start off with some highlights about insemination. We're going to be talking specifically about office-based insemination. And then fertility preservation, a lot more people coming in for fertility preservation, either freezing of eggs or creating embryos with partner or with donor sperm. A lot more insurance companies are starting to offer this elective fertility preservation benefit. So I'm seeing a lot more patients coming in inquiring about this and kind of being proactive in terms of preserving their fertility, especially if they intend to defer pregnancy and childbearing into later years, or if they have any family history of infertility and they're concerned about facing the same thing at a later age. We're going to talk about IVF, or in vitro fertilization, and then we're also going to talk about a really neat strategy called Reciprocal IVF, where both partners, if they're assigned female at birth, can participate very intimately in the process of having a baby. Egg donation and surrogacy are options for all of our patients, including our LGBTQ patient population, albeit not necessarily as widely utilized for female couples, but still potential options. All right, so let's talk about IUI, or intrauterine insemination. So we often call that TDI at our clinic, or therapeutic donor insemination. And in most cases, if you're under age 35, you're going to be advised to complete around 6 cycles of treatment with insemination to give yourself your best chances of success. There's some data that's coming out that the best chances of success are going to be in the first 3 or 4 treatment cycles of those 6 cycles, that the reproductive success rates don't increase marginally as much in the 5th and 6th cycle. So we are, some folks are kind of weighing that and considering moving forward to a more successful treatment such as IVF, if not successful after 3 or 4 cycles. But generally the chances of success are quite good. With donor sperm, typically we're looking at success rates in the 15 to 20% success rate per cycle, and cumulative success rates of 70 to 80%. So quite good if you're under age 35. One important thing to note is that when the insemination is happening, we are using 1 full vial of donor sperm, and that's going to be sperm that's prepared for intracervical or intrauterine insemination. So you'll see it labeled as ICI or IUI on the donor sperm bank websites. And it's a pretty simple procedure, actually. We time your ovulation. You can either do that at home with ovulation kits, or we can take care of that for you and do the blood work and ultrasound monitoring. So there's a little bit less stress. And if there's any ambiguity about your cycles, or you need to take medications to induce ovulation, then the monitoring is very, very key to assessing and aligning the right time for the insemination to happen. The goal for that is to do the insemination a couple of hours before the egg or the eggs, depending on the treatment, are being released from the ovary. So typically we align that timing. And then the procedure, like a pap smear, you're typically in the same position as you would be to get a pap smear. And then a very slender catheter, usually the same kind of caliber or diameter as a spaghetti noodle, so very slender, is placed through the cervix, and then the sperm is instilled into the uterine cavity. For most people, this is pain-free or mostly pain-free. Some people may have some cramping associated with that, and of course, there is the speculum. So there can be a little bit of discomfort with that, and you can certainly have your partner with you at the time of the insemination, and so you can both participate in that. Okay. If you're older, if you're over age 35, we usually recommend proceeding with a more aggressive treatment like IVF after 3 cycles are not successful, maybe 4 cycles, depending on your particular case, because the chances of success per treatment cycle are a little lower. Even if you're not infertile, even if you've never tried for pregnancy before, they're about 10 to 15% per cycle. So the cumulative success rates are about 50% over the course of 3 to 6 rounds. And so more people would need a more aggressive treatment option like IVF, and many insurances will also cover it at that point in your journey if you haven't been successful with insemination. I did put a couple of costs here, just insight for you. Many insurances will cover some treatment costs. If they don't cover it, it's about $500 for the IUI itself, and about $1,200 to $1,400 for the monitored cycle. So you can speak with your clinician and figure out which pathway is right for you. But in many cases, if you're able to track your cycles, the ovulation-based approach is a nice sort of less expensive way to enter into treatment. And the cost of a vial of donor sperm varies a little bit based on the sperm bank. Typically, we work with all sperm banks, but the main 3 that we typically see patients purchasing from, and we have links to those on our websites, are California Cryobank, Fairfax Cryobank, and Seattle Sperm Bank. And so you're going to see those links, and you'll be able to take a look at those, and you'll be able to take a look at pricing as well. They're pretty transparent, usually about $800 to $1,000 per vial of sperm. Maybe increasing a little bit, and the inventory is constantly changing. So if you don't find what you're looking for, check back and check multiple sites. IVF, I want to mention a little bit about IVF treatment and compare and contrast it to IUI. IVF is highly successful, and particularly if you're under age 35, the success rates of IVF treatment can be as high as 50% per treatment cycle. So extremely high, much higher than IUI, but may not be indicated at the first step of your journey. For most people presenting with the use of donor sperm, they're not infertile. They haven't tried for pregnancy before. They haven't been pregnant before. So insemination is often the right starting place, but IVF is a very good backup option. And in some cases, like cases of fallopian tube obstruction, if your fallopian tubes are blocked, it actually will be your first starting place. IVF, unlike IUI, requires injection medication to stimulate the ovary. Usually you're taking those for about 8 to 12 days and coming in for routine blood work and ultrasound pretty frequently, every couple of days during the stimulation. So it's a busy stretch. You're taking the shots at night and coming in for the monitoring every couple of days in the mornings. We at Boston IVF have a lot of satellite locations. So you'll find, take a look at our website, see our geography, but hopefully you'll find a center that's close and convenient for you. There's lots in the Boston location, Waltham, Brookline, Stoneham, Quincy, and then we're out in Western Mass as well. So a lot of clinic options available. We also have New Hampshire and Rhode Island and Maine. So take a look and see what's most convenient for you. And also our representatives can always let you know what would be the closest site for you. In terms of IVF, one of the additional benefits of IVF is that you can choose to genetically test the embryos that are created from IVF. And so that genetic testing can be a huge draw, either for people who have genetic diseases that they're trying to test for in the embryos, or actually to test embryos for chromosomes to understand whether the embryos are chromosomally healthy or normal or chromosomally abnormal, and that could result in miscarriage or a child with a chromosomal abnormality. So with IVF, we can actually test the embryos because the eggs are extracted in IVF combined with sperm in the laboratory, and then embryos are cultured in the lab and they can be tested. IVF is a lot more expensive than IUI. We are seeing, very good coverage for IVF treatment, however, and more encompassing treatment that's impacting in a very positive way LGBTQ population. So, check with your plan. Even if you don't think you have coverage, you might have something. So if you are interested in this pathway, definitely check with our financial coordinator to see if any coverage exists. I did mention a little bit about reciprocal IVF. That's again for two individuals who are assigned female at birth who would like to both participate in a very intimate way in the process of having a child. It requires one partner to undergo the ovarian stimulation process and then have the surgery to extract the eggs. And then embryos are created in the laboratory with the use of donor sperm. And then the embryo can either be transferred into a synchronized cycle into her partner, or it can potentially be frozen, maybe genetically tested and transferred in a separate cycle where the partner has the uterine lining prepared to receive the embryo. So obviously an opportunity for amazing and tremendous involvement of both partners and really excellent success rates. We've studied our success rates with partner-assisted reproduction or reciprocal IVF, and they're really, really fantastic. In most cases, in most age groups, better than conventional IVF treatment, mostly because there typically isn't a strong history of infertility for couples who are considering reciprocal IVF. Also, we have fertility preservation options for transgender individuals. And we are really a center that's done a lot of work in this area to not only help support our trans individuals undergoing fertility preservation treatment, but also to educate and inform other fertility clinics that don't have as much experience. So we've done a lot of research in this area and published a lot of good studies to inform providers about kind of standard of care and put some data into an area that was sort of data free, where there wasn't a lot of experience with trans individuals going through a fertility preservation. So for transgender males, egg freezing or freezing of the ovarian tissue are options. Some transmasculine individuals will actually opt to carry pregnancy as well with insemination with donor sperm or in some cases partner sperm. And then reciprocal IVF could be an excellent option as well. Particularly for our trans folks who are joining in today, some of the things that we've done at our center is to really try to help facilitate an open, inclusive environment. There's a lot more insurance coverage coming through for fertility preservation for trans individuals, including, the sort of standard Massachusetts-based plans have very good coverage, typically for one treatment cycle. And one thing that I always share with our transmasculine folks is that it is possible to consider doing a treatment cycle for egg freezing without actually inducing a period prior to treatment. So you may not need to be off testosterone for a very long period of time, and you may be able to actually accomplish a treatment cycle without having menses. And so that is something you should talk to your provider about, and I'm happy to help in any way that I can. One thing that we can also do is transabdominal ultrasounds, just to help kind of facilitate it being a little bit more of a comfortable process for you. And we can do some less frequent or more flexible monitoring for you if needed as well. And ultimately, I think a lot of this comes down to rapport with your medical provider, talking about what you're comfortable with, what you're not comfortable with, and then finding a plan that suits you. This is one of our larger studies that came out in 2019 on assisted reproductive technology outcomes in female to male transgender patients. This is really the leading study back in 2019 that came out. And what it really showed is that when we matched patients who had gone through a treatment, trans individuals who had gone through treatment, their success rates were similar, if not better, to most patients who are cisgender undergoing fertility treatment. And there did not appear to be any impact of testosterone use, any adverse impact on reproductive outcomes, including IVF treatment with the intent of creating embryos or transferring embryos for pregnancy. And most individuals were successful within one treatment cycle of achieving the number of eggs or embryos that they were looking for.